This is a slightly older patient, about 18-year-old guy, who was actually born in India, and at the age of 4 years went to United States, and then he ate a lot of hamburgers in the United States, became put on weight. So he was advised by his physician to exercise, and while exercising he had a near syncopal episode, almost like a syncopal episode. So the physician, who lived about 200 miles from where I live, did an electrocardiogram and saw that there were STT changes in the lateral leads. In the lateral leads, there were, like in AVL and V4 to V6, there were STT changes, inversions. And so he did an echocardiogram and was horrified when he saw the echocardiogram and he saw the LV function. And so what he did was to send the patient to me. And this is what I did. When I did this echocardiogram, you can see this very clearly. This is the aorta, left ventricle. And my question to you is, watch it very carefully. And what is the ejection fraction? I mean, we always, we don't do the biplane Simpson in most patients. We just look at the echocardiogram. How many of you think
around
it's...
25?
35?
25?
35, 25. Anyone else thinks it's less than 25? Okay, raise your hands, please, in the audience. How many of you think it's, how many of you think Dr. Vijay Lakshmi is right between 25 and 35? Anyone dissents? Okay, correct, okay. Okay, now how many of you, so this is, I thought this was actually, like a dilated cardiomyopathy, except that the STT changes were a little bit...
It's a non-compaction also. Is there a non-compaction?
Non-compaction, yeah, we were worried about that. And so now how many of you believe in miracles? You are in Brahma Kumaris here. Raise your hands, how many believe in miracles?
We
Don't
do.
believe in miracles?
Miracles can happen.
Okay, see now what happens here. So here is the very poor function, and I'm doing the exam, and I just did something here, a miracle I did. I performed a miracle here. And here is the guy with what looks like abnormal ejection fraction. So now what happens to the ejection fraction? It's the same examination I'm doing.
Normal.
How many of you think it's normal ejection fraction? Anyone
It's
disagree?
Almost normal.
Normal?
Yeah.
So what happened here? Miracle, right? I mean,
Was
you
there
know,
a pause?
Dr.
No, thrombus could have been, thromboembolism and then the recovering of the left ventricle apex.
Okay. You give a talk on cardiomyopathy, right? So
Yeah.
when you have a patient with dilated cardiomyopathy, poor function,
Yes.
send the patient to me in Birmingham. I will make it selection normal.
This is a disease called the myoma, or that has some slowing of the cardiac function arrest and then resuming everything again.
Show you again? You want to see it again? Okay, well, let me keep on going. So you'll see it again anyhow. It will come. Right there, poor function.
Yes, I'm talking the same.
Poor function, and this is normal function. See?
Is it in the same setting?
So miracles do happen. And so if you remember the history, you'll probably make the diagnosis in a minute here. Now, what's happening here? This is the apical view. So here's the left ventricle, left atrium. And here is what you see.
There is a layered thrombus there.
What is that? It's compressing the LV wall. I mean, 18-year-old guy, why would he have a thrombus, right?
Yeah, it is a thrombus.
Yeah.
Layered, that's so.
And we had some Indian fellows with me from India. I always have 3 or 4 fellows from India. And I say, hey, that's hydrated cyst, typical hydrated cyst. You know? Oh, I say, okay, I haven't seen hydrated cyst before. So I say, okay, I'll believe you. So that's actually the typical hydrated cyst in this patient. You know, you have the, and then how do you explain the EKG changes? So what I did was to turn the color Doppler on, reduce the Nyquist limit here, you can see, because I thought if the coronary arteries are normal, you're not going to see anything. But if there is a hydrated cyst which is compressing the coronary arteries, what you will see? You may see the coronary arteries. So here is what I did. I turned the Nyquist limit down, and I can see these intramyocardial coronary arteries. See, right there?
Yes.
And the velocity in these coronary arteries, when we examined by pulse Doppler, was 1.6 meters per second. And from experimental data from Mayo Clinic, the velocity in the intramyocardial coronary arteries is only about 1.2 maximum. So there was compression of the intramyocardial coronary arteries in the lateral wall, explains the lateral EKG changes in this patient, the EKG changes. And I did actually an angiogram because the patient referred to me. I said, well, there's no need to do angiogram. I said, let me just be sure. In an angiogram, here is the coronary arteries, intramyocardial coronary arteries. And then I found that there was systolic emptying of the obtuse marginal branch of the circumflex vessel. That again went for compression of the coronary, which is very rare with hydrated cyst. Now the
Actually-
story doesn't end there.
Actually, milking of the coronaries occur with the bridges, myocardial bridge,
Yeah,
but
but-
not with the hydrated.
But this
Yeah.
would happen here.
Yeah.
Yeah. So now this was obviously he was playing with dogs before when he was 4, I'm
Yeah.
sure. So he got the hydrated disease from there, and doesn't occur now. So we made a very good diagnosis of hydrated cyst, and then I told him that listen, this hydrated cyst is compressing the coronary artery, so it's a very large one. So I think we should recommend surgery, and I thought it was a pericardial hydrated cyst.
So by just turning the patient, you had removed the compression?
Yes, just by actually I was angling around,
Manual,
and I said,
yeah.
"My goodness!" I was saying, "My goodness, what a dilated cardiomyopathy!" Angling around, and suddenly I found normal
That's a
ejection
miracle.
fraction. Then
That's
when
a
we did a full
miracle.
exam, found the hydrated cyst. So the now here, just like what happened to your patient, the surgeon said, "Listen, we have a new technique now: MRI, CT scan." I mean, I believe you. You said in pericardial hydrated, but how do I believe? I don't believe you exactly. Why not we get the MRI done? So when we got the MRI done, they said, well, this is a not only pericardial, it's an intramyocardial tumor, cancer. So now I have these, you know how Indian patients are. All the relatives from all over the United States had come to watch the surgery. And so about 30 people here, and I told them not to worry, it's pericardial cyst. And now the MRI report comes and says this is a cancer.
Okay.
So the patient by the time said, well, let me think about what to do. So he went back to 200 miles away. And so I called the physician. I said, listen, I have some Indian fellows with me. They're very sure it's hydrated cyst. And I think I agree with them. I went to saw some pictures. So I'm very sure of it. So what you should do is exclude the hydrated cyst. How do you exclude it? In my time, we used to do Cassoni's test.
Yeah, Cassoni's test.
Cassoni's test. Nowadays, there are some newer tests, which are serum-based tests. And they are done in the CDC in Atlanta. This is the Center for Disease Center. So the physician says, I'll take care of it, don't worry. He comes back after 3 days and tells me, it's not hydrated cyst. I'm very sure of it. I said, goodness. So now here the surgeon. Now the surgeon had told me, because it's a large hydrated cyst, if it's a hydrated cyst, for sure, he would open from the left side and take the hydrated cyst out without rupturing. If ruptured, you have got problems. It'll
They'll
embolize.
go for anaphylactic reaction.
It'll embolize everywhere and anaphylactic shock. But now that your friend is saying it doesn't look like a hydrated cyst and the MRI reports comes up as cancer, I will open it from midline and take a biopsy. But then when you open from midline,
But that would be dangerous. If it is hydrated cyst and if he tries to do biopsy,
Yeah.
and it could be hazardous.
No, but what I'm saying is he believed the MRI, no? MRI plus this guy he said he did the test, necessary tests, and therefore it's not hydrated cyst. So I was wrong, obviously. So he said, I'll take a biopsy. So when he opened the chest, he found it hydrated cyst. Luckily didn't rupture it.
All daughters were there.
And then with some people, they enlarged the incision, completely opened it, and he was able to take out the whole hydrated cyst without rupturing it.
Along with the daughter's
Yes,
cyst.
then I called the doctor. I said, what happened? How did you said you did the test for hydrated disease. He says, no, I was having lunch with my radiologist colleague. And he said, there is a very simple way to check if hydrated cyst or not. If it's a hydrated cyst, it has to involve liver. It's very common to have hydrated
Yes.
cyst in the liver.
Correct.
So he said, I'll do ultrasound scan of the liver. He charged for that also. And there was there was no hydrated cyst in the liver. So he told him no hydrated cyst. So I didn't ask him exactly what test he did. But I assumed he will go to CDC. He didn't send the serum. They said, it's a waste of time. My radiology colleague is very sure. So that was the thing. So what I learned was that you should not believe anyone. You should really go into details of whether he sent the serum or not. And that's the thing. And the other thing is, of course, that it's not essential to do other tests. If you're pretty sure the intrapericardial cyst compressing, there really no need to do some other tests, like just to follow only what you were, Dr. Parashar was saying. There's no need to do now. Then, of course, and then at that time, albendazole had just come on the scene. Was just approved about a month ago in New York. It was only available in New York. So you're able to give albendazole to him. And he did very well. And I saw him at Bombay airport 1 year later, and he's very well. He had lost weight, but he was doing very well, no problem at all. And so that's how just to give you some story, which some valuable lessons here. And also very important, the technique of echo is very important. It is very important not to rely on someone to pick up the transducer whenever there's any case. You do it yourself. and you will get much better results from that.
That is the reason the EF was normal in the second look. The EF ejection fraction was normal because the tilting, the cyst would have gone up away. So it improved the LV function.
Yeah. Because you showed what looked like a very hydrated cyst to me, so I thought I'll show this case, here, Yeah.
So that was an excellent presentation and the excellent...
Before, if I had got the CDC report of hydrated cyst, we would have given albendazole in the beginning only to try to reduce the size of the cyst. Sometimes you can reduce the size of the cyst with albendazole, and then you would have been able to, would be easier for surgery.
So thank you very much, sir. That was an excellent presentation. Please give him a big hand.